see. Start. All right, we're good. All right, so today is all about motor unit and myopathic diseases. Does anybody know what the motor unit is? What is it? Okay, look on page 789, and you'll see where we're talking about, anatomically today, of what is being disrupted, how it's being disrupted, what's causing the issues. The motor unit, wow, this is going to be great, isn't it? Motor units are what connecting your nerves and stuff into your spinal cord and sending the muscle or the signals back and forth. So it's really a disruption in the signals being sent to your muscles in order to create normal movements. Okay. The first one that we're going to talk today about is one of the most common ones, and one I've treated. This is the one I've treated out of all these the most. Okay, this is Guillain-Barré syndrome. Has anybody ever heard of Guillain-Barré? No? Have you seen it in the outpatient clinic or anything, Allie?
I think I've heard of it. I just can't see it.
A lot of people recently started talking about Guillain-Barré syndrome with COVID vaccines. A lot of people, it was coming out, people were developing Guillain-Barré syndrome from vaccines, and, that's been debunked and stuff, but it was really big there for a while. People were saying, oh, it can cause this, oh, it can cause that, like everything else, but you hear that a lot. You have seen it. It is. It's pretty wild. The lady that I worked with, like from start to finish with it, she was a really interesting lady. It just boom, hit, and it does. It pretty much kind of hits. And she was a chef. And it really, as I go through this disorder, you'll see how that affected her life. But she ended up making, I don't know if it was ever 100% recovery, but I worked with her all the way through the inpatient phase of it when I was at Genesis. And she was able to function fairly independently, but she did not have the fine motor coordination and stuff that she did. There was a lot of stuff that I don't know if it ever did come back, but she did get discharged and went to outpatient and home health services too. Yeah.
And she's still in the wheelchair.
Yeah. Some people, I'll tell you too, this lady that I worked with, she had the best recovery I had ever seen with GBS, but she had a lot of motivation. She was young. I think she was 35, somewhere between 35 and 40 when it hit. So her entire life just flipped upside down. All right, so let's talk a little bit about this. GBS is acute. It is life-threatening. You see a lot of severe muscle weakness. This can even involve muscles down to... You're fine. I'll have a moment of silence for Lindsay's dead pin.
I know that.
All right, I'll start over. It's acute. It's life-threatening. You're going to see severe muscle weakness, but I want you to think of when we're talking about muscle weakness with a lot of these disorders, you're talking even, some more very basic stuff like the muscles that are able to give you speech and swallow and breathe. All of these muscles can be affected. It can affect any age, but usually occurs after some type of a viral infection of the respiratory or GI system. Okay. There are 6 known subtypes of GBS, and they're on page 789. You have acute inflammatory demyelinating polyneuropathy. Big old name, AIDP. It is the most common form of Guillain-Barré, and they often use the terms simultaneously. They'll say Guillain-Barré syndrome, acute inflammatory demyelinating polyneuropathy. Okay. The second subtype is Miller-Fisher syndrome. It's a rare variant of GBS that usually affects the eye muscles first. Are you guys seeing where this is in the book? Are we good? Okay. It's number 1 on 789. Yeah. We good? Okay, cool. All right. The third one is acute motor anoxyl neuropathy. This is prevalent in China and Mexico, and the disease may be seasonal and recovery can be rapid. I've never seen that one. All I've ever even really heard of that one is what I just read you. 4, acute motor sensory anoxyl neuropathy. It is similar to the third one there, but it also affects sensory nerves with severe damage to the axons. The difference with this one is recovery is very slow and often incomplete. The lady I treated was the acute inflammatory demyelinating polyneuropathy. Number 5 is acute panonomic neuropathy. This is the rarest variant of GBS, but it is often or sometimes accompanied by encephalopathy, which is what? Anybody know? From your book.
Brain disease.
It's a brain disease. Very good. And it's often associated with a very high mortality rate. And then number 6 is Bickerstaff's brainstem encephalitis, BBE. This is characterized by an acute onset of a paralysis in the eye muscles, ataxia, a disturbance of consciousness, hyperreflexia. These are all way more rare. Like I said, in my experience, I've only seen the first one. I've not seen those other 5, but it is, if you get somebody who has Guillain-Barré syndrome, but you see acute panonomic neuropathy as a diagnosis on there too, you're going to see a totally different patient than if you saw, the first category, right? Basically, what's happening with Guillain-Barré syndrome is the body's immune system is attacking itself. And where it's attacking itself is at that myelin sheath. Maggie, what does the myelin sheath do? What's another disease that attacks the myelin sheath? We've talked about. Cassidy, what's another disease we've talked about? Uh-huh. Yeah. Good job. Often. So what does the myelin sheath do, Isaiah? Okay. It's kind of like a protective coat around the neurons that when you're sending the signals, when your brain's trying to send the signals to your muscles, it's that protective coating that goes around it. When that gets damaged, the signals will often get lost. They literally are like when they get there, they shoot out there. They can't follow that path. Some of the symptoms that you're going to see is prickling, like needles and pins in the fingers, toes, ankles, and wrists. Weakness in the legs that spreads to the upper body and may even result in total paralysis.
When you say myelin, you mean myelin sheath?
Yeah. Yep. Unsteady walking or the inability to walk or climb stairs. Difficulty with eye or facial movements, including speaking, chewing, or swallowing. Severe pain that may feel achy or cramp-like. Difficulty with bladder control. A rapid heart rate. Low or a high blood pressure. Difficulty breathing. There's all kinds of different symptoms. It's a nasty disease. How they diagnose it is also on page 789. You can kind of see a picture there of how it's done, but it's electromyography or an EMG. It's like an electrical test of the nerve and muscle functions. Okay, they're just testing to make sure that the signal, that electrical signal is actually being sent out to the muscle correctly. Okay. All right, so what are some treatments? There's no known cure, but there are different therapies that people go through that help with the symptoms and symptom management. They will do a plasma exchange with patients sometimes. My lady did not have a plasma exchange, but they will do those. And a high dose of immunoglobulin. So as far as exercising with patients that have Guillain-Barré syndrome, what do you think that would look like? Okay. Why did you go with range of motion? What's your thought process behind that?
Well, you said they start having weakness.
Okay.
So I just figured kind of keep the muscles.
Okay. So is range of motion, do we consider that high or low level? It's low level, right? And you're right on your thinking. You want to kind of start out low because you don't want to overdo it with patients with Guillain-Barré. Sometimes even doing like basic ADLs when you start working with a patient is like an extreme hardcore workout. It's like you can easily overdo it with somebody who has Guillain-Barré. Normally, patients, if you start them on like a strengthening, that's much later because it does take so long for somebody to work through an onset of GBS. You want to make sure, again, that you are not causing the patient any pain, or if they are telling you, hey, this is too much, this is the patient you listen to, okay? If they say, this is way too much for me, it's cool to stop. Now, you're going to have some of those patients that you're like this is way too much, and it's not. It's not the case with the Guillain-Barré syndrome. If they are telling you that this is too hard, you're doing it too hard, okay? Or you're pushing them too much, okay? Any questions on Guillain-Barré? And I've got videos I'm going to show you guys at the end of what some of them, what they look like, okay? All right. Now, we're going to talk about myasthenia gravis, or MG. This is an autoimmune disease. This is like your immune system is attacking your body's own tissues. It starts to attack the what's called the neuromuscular junction. This is the connection between your nerves and your muscles. That's where it's attacking. It's not hereditary, but they do see a genetic role there. But it's not necessarily hereditary. A lot of the times, MG will affect muscles that control the eyes or the eyelids. Facial expressions and swallowing are the most frequently affected ones. But if you want like a gold star, how to remember it by, like hallmark symptom, it is that the muscle weakness gets worse with exertion and sustained activity, but it improves with rest. Okay? Now, doesn't that sound like just normal muscle though? Like when you guys do something that is physically demanding, aren't your muscles feeling weaker at the end and then it improves with rest? So how can you tell the difference between that being like normal and like you've overdone it? Maggie, how can you tell that difference? Yeah, so I just told you that the muscle weakness with someone with MG, it gets worse with exertion, right? But it improves when they rest. How can you tell the difference between it just being like normal, like if you didn't exercise, your muscles get weak after a while too, right? And then when you rest, it gets better. Well, why is that different with myasthenia? Okay. Yes, you're right, but your timeline's a little off. So when you do if you go and you work out and you go rest, let's say for an hour or something, you're not at the point where you can't move, right? Like you're not. These people will be. It takes a lot of rest to get back to functioning correctly. You might be a little sore, but you can get up and do your thing, right? It's different with people with MG. It takes a lot of rest to get back to that. Okay. It's very important that we talk to clients if they have like increased exacerbations, they keep getting more and more flare-ups, that we're going to manage symptoms rather than just, do exercises and stuff. We're going to help manage their symptoms. That's all through the occupational stuff, right? So you're going to educate them about what makes these exacerbations worse. If they have insufficient sleep, that's a big trigger. Stress and anxiety, any type of like additional illness, if they catch a cold or something like that, that can make it worse. Overexertion or a repetition of motion, like over and over and over and over. Okay. Pain is a big one that causes it. There's a lot of these. So I recommend you write these down or highlight them. They're in your book too. A sudden fear or even extreme anger can cause more exacerbations or make it worse. Depression. The big one here, put a gold star beside, are extremes in temperature. They need to avoid going out in extreme colds and extreme hots. They don't need to be taking hot showers and hot baths, and likewise cold showers, cold baths if they're into that. No extreme switches in temperature. Should not be sunbathing. They should not be in saunas. They should not be in hot tubs. Anything like that. No extremes. That can cause a flare up, and most definitely probably will cause a flare up. And when they switch temperatures, okay. Even humidity outside, sunlight or brightness, like where they can't. My rule of thumb is if they need to wear sunglasses outside, is probably too bright. Okay. So hot foods or beverages that can affect the throat or the mouth. Some medications can do it. Alcohol, quinine or tonic waters, low potassium levels, low thyroid hormone levels, some different chemicals, even different household cleaners, bleach, pet flea sprays, all this stuff. So I just named off like 20 different triggers. How do you think these people's lives are? Difficult. Why are they so difficult? Why? How would you describe this person's life? Very, very restricted. They literally have to think and watch about everything they do because it can cause an extreme fatigue. Okay. All right. Any questions on that? Are we good? All right. So what are some things that they're doing as far as medications goes? They'll give them medications that suppress their immune system, because remember, it's their immune system fighting their body. So they'll give them immunosuppressant drugs. How do I want to put this? So Isaiah, now knowing what you know about MG, what would be a treatment intervention you may do?
I'd probably start with some craft probably. Seated, that would be
Okay.
good for them.
Okay. Okay. Jennifer, do you think you can exercise with these people? Could you do some Therex with these guys?
Yes.
It would vary. Okay.
Maybe like a chair.
Maybe like a chair exercise. All right. Generally, with patients that have MG, you can do exercise as long as they're not flared up. Okay. Now, here's the thing: you're not going to send them to Planet Fitness and have them do 30 minutes or whatever on an elliptical. You light exercise, light stuff. You're not out here to make them a marathon runner or whatever. You want them to perform their daily occupations independently, right? That's our goal. So you don't want them, they shouldn't be sweating and getting their hot temperature up, and you can't be having them get really overexerted because you're going to cause a flare up. Okay, so you can do exercise as long as their symptoms are okay. And some can even tolerate a little bit more if they're on immunosuppressant drugs and it's keeping that, their immune system from fighting themselves. So definitely keep that in mind too. Most people by the time they get to you, unless you're in like the acute setting, if you're like outpatient or whatever, and you're treating this person, most of them are on those immunosuppressant drugs by that point, if it's bad enough for that. Okay. All right. Any questions on MG? Are we good? All right. Post-polio syndrome. This is where polio survivors pretty much have to go through polio again. How awful. You beat polio the first time, then you have to go through it again. It's sad. These people, it's very, very difficult. Polio was massive for a lot of patients, or for anyone that had it. And it was a big worldwide thing, right? And the fact that they beat it once and thought it was over and then they have to go through it again, it's really, really difficult for a patient to accept. Okay, so.
Isn't this dangerous system like chickenpox?
No, this is a different syndrome. I'm not exactly sure of if it's polio redone, because it's not polio, it's post-polio syndrome. So it is different than polio, but it's pretty much very similar. And I've got one of the cool videos I got today is like some aquatic therapies that they do. I feel like this diagnosis is going to go away eventually because, polio is pretty much eradicated from the earth. But, eventually. We're not in that phase where we're not going to see it anymore. But, the next generation probably won't see this. It'll be gone. Well, what was I going to say? Oh, I'm going to go to the next book. A number of different controlled studies, okay, as far as medication goes, or as far as therapy goes. Non-fatiguing exercises are always the best, okay? So what would be an example of a non-fatiguing exercise? Jennifer, what's a non-fatiguing exercise? Chair yoga. Interesting. That's a thing? How do you do chair yoga? How do you do the downward crane in a chair? A lot of you guys have talked about yoga. Are you guys really passionate about yoga, or you guys can get really cool certifications of that and go a long way with it. So just throwing that out there if you're super interested in it. Everybody, that's like the fourth time in the last couple of weeks that somebody's brought up yoga. What's another non-fatiguing type of exercise, Cassidy? Okay. I've not done either one of these interventions. What's another one? What's another non-fatiguing exercise, Isaiah? A little more common than Tai Chi and chair yoga.
Tai Chi is pretty common.
A fourth of the population does Tai Chi.
Well, if you consider that,
it has been.
Consider that China is a fourth of the world, and most of them do Tai Chi, then yeah, like at least 10% of them.
I'm gonna say, how about range of motion? That's another one. That's a little more common than Tai Chi and chair yoga. But that was his original. I don't even know how that needs to be on somebody's final practical. Like, I want someone to come in and teach the patient chair yoga for their patient.
We're all yoga now.
All right. Another, lower non-fatiguing exercise is light swimming or, movement in the water, because, you got the resistance there with it as for exercise, but they also are, weightless. So that's another one. Aquatic therapy is very helpful with post polio. As a general rule for patients with post polio is no muscle should be exercised to the point of causing aching, fatigue, or weakness. Okay, so it should all be very light exercise. This is not somebody you're going to continually get worse or not worse, grade up, grade up, grade up, grade up, grade up. You're going to try to, it's going to be a very, very light, gradual increase over time. Okay. So there's no pharmaceuticals that are really out there. Not any really surgical approaches. There's just not a lot with post polio. Just remember, as far as we're concerned, that the non-fatiguing exercise is where we're headed. Okay.
Found the most popular theory as to why it exists.
We'll share it with us, Isaiah. I'm sure you have it.
So polio affects your body and attacks your motor neurons and destroys them, whatever.
Right.
But to do this, your body compensates by creating more branches or something off of the axon.
Mm-hmm.
But then that over the years is not something your body's able to handle. And so again, the neurons get shut down and destroyed by your own body just using them too much. And so you go back into polio again.
That's interesting. Well, thank you.
The predominant theory. No one knows exactly.
Yeah, I was about to say nobody knows. It just kind of, it's like a flare up in polio. It's very strange. All right, so now we're going to go into some of the muscular dystrophies. These are extremely common. A lot of them are, you're going to see these muscular dystrophies with in pediatrics. So I have not had a ton of experience with muscular dystrophies. I've worked with like probably 3 or 4 because all of my stuff has been in geriatrics. Now you talk to a pediatric therapist, they've worked with a ton. Okay, so we're going to go through each one because they are similar yet different. Okay, so we have Duchenne's muscular dystrophy and Becker muscular dystrophy. Okay, these affect men and boys only. Okay, these two specifically are men and boys only. Women can be carriers of the gene, but they don't have the disease themselves. Okay. Both of these disorders cause difficulty with voluntary motor control. But there's some age differences here, okay? With BMD, most of the time men with BMD walk well into their 30s. But boys with DMD often stop walking around 8 to 10 years of age. Okay? All right, so some of the first signs of BMD may be trouble walking fast, running, or climbing stairs. Then boys with DMD, they may be late walkers. And as toddlers, they may have a lot of trouble getting off the floor, running, or climbing stairs. How they diagnose this is with genetic testing, an EMG, that electromyography, and then just looking at like family history and symptoms is one of the biggest ways. They're pretty common like symptoms, like they can look at and say, oh, that's probably that. So some other presentations is by adulthood, clients that have Duchenne's muscular dystrophy are normally totally dependent for all ADLs. But the majority can still use like a power wheelchair or a phone or a computer with some adaptations, those kind of things. But they're completely dependent for ADLs. A lot of men with Duchenne's muscular dystrophy can, if they're using their power chair, a lot of times they have like the joystick control because it's a lot easier to use a power wheelchair with one of those. I've seen some power wheelchairs that have like buttons. It almost looks like a game controller, and they just press forward, back, left, and right. But the majority that you're going to see around here anyway comes standard with the joystick because most, it's one of those things like the universal design of a like a doorknob. Remember how we talked about that? Like anybody can use the joystick from, you know, somebody who's well advanced and somebody who's not so advanced. In adulthood, the Becker muscular dystrophy, they're still ambulating, they're still working and performing all daily care tasks without assistance. Okay, so DMD, they're completely dependent for ADLs. Becker's muscular dystrophy, they're usually independent. Okay, we good on the difference there? So a lot of the medication is not really used for treating the disease more than it is just symptom management. With Duchenne's muscular dystrophy, you know, the more severe one that we're talking about as far as adults go, we're going to be focused on preserving their strength for as long as what we can. A big risk factor for Duchenne's is obesity and osteoporosis. So we have to educate them a lot on, you know, proper diet, things like that, because if they are obese and they have Duchenne's, it makes it much more difficult, and their level of independence is going to go rapidly downhill much faster. Okay. A big one is prevention of contractures. You don't want them getting locked up. You know, that's going to make it way worse. Even to grab, if somebody's got, you know, contractures starting in their hands, that's going to make it even difficult to use a joystick, you know. Let's see. Some interventions that we're going to do are exercise with these patients within parameters, what they can control, or we don't want to overwork them. Flexibility and stretching is really important with both of these, making sure that they maintain as much, as much range of motion as possible. Decreasing pain. There's some gold star things here I want you guys to definitely remember. Is with Becker's muscular dystrophy, you're going to combine a lot of aerobic and strengthening exercises in. So the more or less severe one. And then with Duchenne's, really nutrition is one of the biggest things that we teach, and contracture management. Okay. So if I ask you which one of these you would typically see is worse and a poorer outcome, it is which one? Duchenne's. Very good. Any questions on those two? Are we good? I'm going to go through one more, and then we're going to take a 5-minute break, let your brains take a rest, because this is a lot of information. Okay? All right. Charcot-Marie tooth syndrome, or disease, sorry. CMT. This causes weakness and numbness in the extremities and often is very painful. It usually starts in the patient's feet. There are a lot of genetic studies with CMT. They believe that there's a lot of genetic link with this one. The most common type, or most common kinds, their symptoms usually begin before they're 20 years old. And here are the like telltale signs of CMT. Foot contractures with very high arched feet. So it'll be like that on a foot. Very high arch. Hand contractures, a lot of deformities in the hands. A loss of muscle in the legs and arms, and it always starts distally first and works its way. Foot drop. Have we covered foot drop before? Does anybody know what foot drop is? Yeah, we have or haven't? I've got a yes and a no. I know you've probably seen foot drop before. Do you know what foot drop is, Lindsay?
We talked about it in Canadian recently.
Okay. So foot drop is literally when someone picks up their foot drops. You know, when you normally take a walk, you have a little bit of a drop, but it's nothing like they pick up their foot and their foot goes, it just drops down. A lot of the times we'll control that with orthotic device. I typically will let physical therapy do that part of it. And I'll work with how to put it on and stuff like that, and how to balance for ADLs and whatnot as far as we're concerned. I have done it before, but not very often. You'll see foot drop a lot with patients with CVAs and strokes too. They'll have that weakness in the foot drop on that side. Another telltale sign is numbness in the hands and the feet, difficulty with balance, and pain from the overuse of their extremities. Again, for diagnosis, they're going to do some of these neuro tests and stuff on them, but they're going to look a lot at the genetics. They're going to do a lot of genetic testing. But you can look at some of these telltale signs and symptoms, that high arched feet, the hand contractures and all this, and it's an early onset, right? You're not talking about somebody later with a lot of arthritis and stuff that you might see contractures and stuff. This is an early onset stuff. There's no drugs that are even out there to help slow the progression, but they do a lot of symptom management, mainly geared towards pain and cramping. Therapy is extremely important with CMT, making sure that the contracture management is under control. But, it is a progressive disease. It's very hard to treat. I have had colleagues that have treated patients with CMT. I have not had the opportunity to treat anybody with CMT because it's a younger onset. All right. Do you think, what kind of exercise might you do with these people? Faith, what would you do? What kind of exercises are you going to do with your patient that has CMT? Okay. What else? Isaiah, why might you do stretching? Contracture management, yeah. It's all about keeping the muscles as stretched as possible, right, into like normal patterns. What's another type of exercise you might do, Jennifer? I'll give you a hint. We've talked about it with several of these so far. It's kind of a theme with these types of disorders. What's a really good tool that you can use and exercise with these patients? Range of motion, but what's a good tool to use for doing range of motion? I'm trying to hint at it. I don't know how else to hint at it other than to like act it out. What's a big thing I've mentioned here? Swimming. Swimming is helpful. So you're going to use a lot of these patients are going to have aquatic therapies. I wish that aquatic therapy was used more often with more patients. I just think it's awesome. I love to see the progress that patients do and the freedom that they feel in the water. All right. Are we good? All right. Let's take a quick 5-minute break. Let your brains rest for a second, and then we will do the second part of it. Okay. So 11:35, 11:36. Cool. Make sure you guys answer that weekly prep question that I posted on the Facebook page. Make sure that you answer the question on the Facebook page, the weekly exam prep question. Has anybody attempted recently to try to get on the module 4 for Jerry's? I know you had already done it, but what has anybody attempted to get on it? Can someone try really quick to see if you still have access? For some, AOTA switched their learning platform over spring break, and I want to make sure you guys still have access. Does it give you an error like 404 or something like that? Okay. All right. Well, she's working on that. If I need to do an extension on the module, like if it takes a little bit for them to figure out why that is, that's fine. It's due, I think, Tuesday next week.
Are we gonna go over this exam?
What exam? The one you took already, or the one you're taking tomorrow?
Pick 3.
No, not a single person, I don't think, got any of those.
Did you grade it?
Yeah, I had to. I didn't set up those questions.
No. I don't see it in the grades.
Yeah, mine's not showing
It's
either.
an old test that's in the grades.
Well, that's weird.
On the side, I just got really confused.
It's the first, it's
But
not,
it's in the grade book. It's in the
No.
grade book.
it's showing exam 1. It says exam 1. Yeah. And I looked at the review and the questions are not from the exam.
Okay, I'll check it out. Remind me when this is over, and I will. Okay.
Wait, what? Do your grade book, I think, right?
I had to manually grade because it was. Remember, I told you for those multi-selects, it's all or none, and for whatever reason, it was giving partial credit.
Mine says exam excluded.
Are you looking at Jerry's? Because exam 2 for Jerry's was excluded.
No, that one's over. Or,
I think you're looking at 215. Because that exam is excluded. It's completely out of there.
oh, okay, now I see it.
You good?
Yeah.
Okay.
Did you say no one got
Right.
the They were so hard.
They are hard. Those are the worst types of questions, and I can't do anything about those. Those are just, they're hard. And most people, and the majority of you got 2 of them correct and missed the 3rd one, and that's telltale. I mean, that's exactly, Beckley did the same. You guys did the same. Everyone normally does that.
I'm not very happy about
I have to look at the question. I think I know which one you're talking about, but I have to look at it. And to let you know, I'm writing the ones for the next exam, but Professor or Director Hurt wrote the ones for this one, the multi-selects. If one of them I completely don't, agree with, I'll look at it. But
I know that one about.
now you guys know you have another exam in 207 next week, right? It's only on 3 chapters. It'll be this one, 32 and 33. Let's see.
Is it in seat or?
At home. It's the 3-day thing. Yeah.
Oh, does it open on Monday?
That opens on Wednesday, I think.
I don't like the multis.
Buddy, I don't like them either.
No,
I can't stand them.
The specific life modification.
I don't like them
CHF
either.
made sense to me.
Those are like literally textbook how your exam is, though.
You said it's gonna open.
I think it opens Wednesday and will close Friday at 5, right? Isn't that what they are? Pretty sure. Yeah, because we extended it to Saturday at 5 last time. All right, you ready to move on to this one? Are we good? And then we'll look at all the other stuff after class. Cool. And we'll review each one of those specific questions. Jennifer, I'm going to plan that for Wednesday. There's not as much to go over on Wednesday as there is today. All right. All right, so myotonic muscular dystrophy, or MMD. This affects muscle strength as well as organ function and causes an inability for the muscle to relax at will, which means it'll contract and not be able to relax it. There's a term for that. It's called myotonia. Okay, you're going to definitely want to know what myotonia is, and it's the inability to relax a muscle at will. Okay, there are two types, MMD1 and MMD2. With MMD1, it is either going to begin at birth or in childhood, like an early onset, or in the adolescent or early adult onset. Okay. It is characterized by slow, progressive weakness, cardiac issues, and some mild to moderate cognitive disabilities. The thing I want you to remember with MMD1 is that it affects the distal muscles in like your hands and your feet first. Okay? With MMD2, it has an onset of anywhere from 8 to 60 years old, and it affects the more proximal muscles first. Bless you. So it's going to affect like your muscles for your shoulder, for your hips, stuff like that first. There is a genetic link, like there is with a lot of these, but they're not really sure what that link is. Okay? A lot of the research that's been done on MMD has actually been done using animals and genetic testing with animals and stuff. A lot of the treatment is more aimed at managing symptoms and keeping the patient as able as possible. A lot of the symptoms are managed with medication, like sleepiness, that myotonia. There are medications that can treat those symptoms, but nothing that really treats MMD itself. One extremely important, very, very important thing, that if you're going to do exercise with a patient who has MMD, the cardiologist has to supervise what you're doing. It has to be cleared. There's a lot of cardiac issues with MMD, so you don't want to overwork this patient and then go into cardiac arrest. Okay? So anything strenuous that you really do with this patient needs to be cleared by the cardiologist. Okay? Range of motion is extremely important, just because you don't want them to get tight and start the whole locking up. You don't want any contractures start forming, so range of motion is extremely important too. Okay? All right. We got one more to run through, and it has 4 different subtypes. Okay? This one is I actually know a little girl who has this, and she's done a lot of experimental drugs and procedures and therapies through WVU, and is gaining a lot of independence back from. I did not think this little girl would even be alive at this point, and she's like using a motor wheelchair, and it's actually quite neat. You guys know the bumbo seat over there, as she showed you that in pediatrics, the little blue thing. It kind of looks like a bumbo seat with extra strapping, and it's a little taller, and 4 wheels and a joystick. It kind of looks like a little go-kart. It's really, really, really neat. If I can, I might message her mom and see if I can get some videos and show you guys. But it's pretty neat where they've come, or how far they've come with it. All right, so this SMA is characterized by the loss of motor neurons and is often classified as motor neuron disease. Again, there are 4 types, and all the symptoms can vary from severe to mild based on, SMA drops a protein in those motor neurons. It's blocking the signals by dropping SMA proteins. What is this? I'm at the wrong slide. My bad. Sorry.
Oh, we're not.
No, I apologize. SMA, no. The other two, I'm going to do something else with those. I'm
We're
moving.
not going over the.
No. Go right to SMA. I apologize. Do you guys need me to redo what I just said with SMA, or are you good?
Please redo it.
Okay. Sorry. All right. So again, SMA, or spinal muscle atrophy, is the loss of motor neurons and is often called motor neuron disease. There are 4 subtypes. The symptoms can vary from severe to mild, but it drops like a protein where the motor neurons are, and it's blocking signals that way, and can cause a lot of atrophy to the muscles. What does atrophy mean? Deterioration. It's like a wasting away almost. The big thing here is the weakness. These patients are really weak. A lot of the children with SMA are unable to sit up on their own. They have a lot of difficulty breathing, especially at night. They'll be on CPAPs with high levels, stuff like that. It can be very debilitating to the kids. It affects the weakness is symmetrical, so it's not going to be all the weaknesses on one side, not the other. You often see it's weakness on both sides, and it's more proximal than it is distal. Okay, so the core muscles are actually affected more than the distal muscles in your hands and feet. Weakness is often more pronounced in the legs than it is in the arms when it does start to move distally. Diagnosis is usually done with blood tests. And they're going to do lots of neuro testing and stuff too, along with those blood tests. All right, so we're going to go through the 4 subtypes, okay? The first one is type 1. These children have a very short life expectancy, and they generally die very early in childhood. That's all I want you to know about type 1. Okay? Short life expectancy, and they generally die early. SMA type 2. The symptoms usually begin in babies around 7 to 18 months. Kind of as they start to learn to sit unassisted in that age range, but they're not going to stand or walk independently. Even like the strongest candidates with type 2, if they do stand, they stand in a standing frame or with really supportive braces, but they're not able to walk with those. They're just standing. It can vary a lot with type 2. Individuals might die at an early age or live well into their adulthood. It really just depends on the person, but weakness always gets worse over time. It increases over time. Okay? Cool. So SMA type 3 is that muscle weakness begins in older children and teens. They learn to stand and walk normally as children, but they lose the ability to stand and walk as the disease gets progressive. A lot of times, because they're still developing and growing, you'll see scoliosis start to appear with these patients. Everybody knows what scoliosis kind of looks like, almost like an S-shaped spine. Yeah. Some more less common problems you might see are difficulties with swallowing. A cough can be, common. But life expectancy with SMA 3 is generally normal. Okay. And the last one is SMA type 4, or adult onset SMA. This begins in the late teens or adulthood. but the lifespan is generally normal. It's not really affected. The onset can be as young as 18, but normally you're going to see the onset after 35. You're going to see them have a lot of muscle weakness, tremors, twitching, muscle aches, and fatigue. But they generally still are able to walk. They might walk with like what's called a waddling gait, almost kind of like that toddler waddle looking. But they generally are still able to walk. So what are some drugs? They're not really a lot out there. There's one called Spinraza that is common, but most of them are in trial use. Okay, that may or may not be what the little girl had that I'm talking about. I don't know. I'd have to ask her mom. But as far as surgical and stuff, the majority of therapy that I've seen and actually seen on Facebook, because they share videos all the time of her doing stuff in therapy, has been with physical therapy. They've worked a lot on balance. For occupational therapy, they've done like the bumbo seat looking go-kart adaptations, trying to get the patient or trying to get her to go through these developmental milestones that you guys went over is what they've been focusing the majority of. But physical therapy have been focusing a lot on like core strengthening and stuff like that. Okay. Again, the one I want to specifically point out on OT interventions is Guillain-Barré syndrome. Okay. I really want you guys to know this one well. What are some of the common treatment interventions you may do with someone who has Guillain-Barré? Going back to the first one we talked about. We finished all of them now that I wanted to cover today. What? Range of motion. What was another one? Lindsay, what's another one? Aquatic therapy, yes. Very good. We'll put that as light exercise, okay? So light exercise and range of motion, we'll put those out. What's another one? Maggie, what's another thing you might do? Not well, I mean, kind of, but let's veer away from exercise and go more toward occupation-based stuff. What might you teach somebody with Guillain-Barré? That was a big hint. What might you teach them? Positioning. Okay. Okay. Comp strats, right? Very good. What about adaptive equipment is another common thing? Yep. One cool intervention. Have we talked about hand over hand therapies in here before? Probably. I feel like we've mentioned it. So hand over hand, Maggie, what is hand over hand? Yeah. Yeah. Putting your hand over their hand and doing okay. Why would that be beneficial for somebody with Guillain-Barré? What are you doing with hand over hand? Muscle memory, right? By what? How are you aiding muscle memory? Right, like in a normal pattern, right? So when you're moving it through, say, brushing their teeth, brushing their hair, whatever it be, you're training that muscle, okay? So their body is literally trying to send that signal and you're providing the movement with it, right? You're kind of making that connection. The signal might not be getting to the patient's muscle in order for them to do what you're asking them to do. They're trying to do that and trying to send the signal, but it's getting lost, right? So if you're doing the movement, you say, okay, I want you to reach out and grab the remote, right? You doing that with them hand over hand while you're telling them and while they're trying to do that is beneficial, okay? Where might you see somebody with Guillain-Barré syndrome? What setting would they be in? Okay, so home health services. So somebody gets a random onset of Guillain-Barré, just kind of boom, hits them like a freight train out of nowhere. Where would you see them? You're probably going to see them in acute. Okay. Are they going to go straight home though? No. Where will they go? Like an inpatient rehab, like Encompass, Genesis, these kind of places. Are they going to be there long? Majority of the time, yes, for a long period. Remember, I told you it was like 6 months to a year of working towards getting function back. We worked with that one lady forever, it felt like. So let's talk about some OT interventions for, the myopathic diseases. So again, what settings might you see these patients in? Inpatient, home health. Are you going to see them in outpatient? Yes. Why might you see them in an outpatient setting? You saw them in an outpatient, right? So what were they working on in an outpatient setting?
That was the first place she had been. That's where they sent
Wow, that's terrible.
her.
Yeah, that's terrible. Her insurance probably is a reason for that. Yeah, we hate insurance.
They were just working on like getting out of bed.
Mhm. In an outpatient setting, which is very not typical, right?
How'd she get there? At the time, when her husband and kids all had COVID, she had COVID and then
There's a lot of talk with COVID, not just the vaccine, but just COVID in general and Guillain-Barré and it causing it. It's actually quite scary, the commonalities.
Symptoms like with COVID were perfectly fine. She just felt bad for like a day,
Right.
and then all of a sudden.
Remember, it's caused normally by a viral type of infection on the respiratory or GI tract. COVID affects both, depending on who you are and all that other stuff. It's got 15,000 symptoms, but it's Guillain-Barré has definitely been shown into the light, and there's a lot more cases of Guillain-Barré since COVID. So that's the one I really wanted to highlight, as especially when you guys get out and you're starting to practice, you're going to be treating these patients because you're now in a COVID world. So what would home health therapy look like compared to outpatient therapy, Jennifer, for someone with Guillain-Barré? What might you work on in home health and what might you work on in an outpatient? Okay, absolutely. And with exactly what they have. It's one thing to work with somebody in a long-term care facility and say, okay, we're going to practice toilet transfers. It's another thing to do a toilet transfer in their house in this tiny little 5x5 bathroom that they use, Very good. So how would you switch that up if you were seeing this patient an outpatient? Yeah, you're right. That's later stage stuff. What she was saying with outpatient is definitely not traditional Guillain-Barré syndrome treatment in outpatient. That's just where insurance center, probably because it's the cheapest. So if a lot of these patients are going to go from an acute to an inpatient rehab for an extended period of time, then get sent into home health, and then get sent into outpatient. These patients really should go through that continuum. The fact that this lady did not is awful. I couldn't imagine the lady that I worked with, her being sent home and having to go back and forth to outpatient. It would just be terrible. I couldn't imagine this. These people need a lot of therapy, every day. It's not something they can go to 2 or 3 times a week and expect to get max function back. These people need a lot of work. Very good. So how does OT address these areas with myopathic diseases? What about functional mobility? We'll just go around the room, Isaiah. How would you address functional mobility? Pick a myopathic disease and tell me how you're going to address it. So what is functional mobility?
Get around and move around.
And do what? That's the mobility part. What's the function part of it?
Able to do yourself.
just being able to get around and do your daily tasks, function. So it's not just walking; it's walking and doing what you need to do. So how would you address that with one of these diseases? Pick any one you want.
Sorry, my brain's a little slow today.
Okay, I can come back to you.
CMT.
Okay. So how
Yeah.
with charcot-marie tooth disease? How are you gonna address it?
So they have the eye arches in their foot and the contractures.
Yeah.
And you said is that the drop foot
Hmm.
as well?
Yep.
So you gotta teach them to either lift their foot up more or teach them how to kind of like monitor the fact that their foot drops off.
Okay.
They also have neuropathy, don't they?
Yeah.
They can at least. So monitoring their pain when they step on, basically.
Very good. Very good. All right, Lindsay. So like personal care devices.
I guess that would just be more education,
Okay.
right? Like teaching them the products.
Does it vary for these different diseases, or are you just gonna kind of
Well, some of them might not be able to do it.
okay?
They
Depending
might
on where
have
they are.
Different strategies on how to actually do it.
Yeah. Very good. All right. So any IADO you want in any disease? Tell me how you could treat it, Jennifer. Anything that you want.
I'm gonna pick Pecmare
Okay.
and MG.
Taking MG for 200. Okay.
Yeah.
How you gonna treat it? Pet care.
No, I feel worried about them.
Okay. So how could you come up with an intervention that you can think of that would help them walk their dog, but you don't necessarily want them walking?
Like an inward track.
That's interesting. What? How does that help? Well, tell me where you're going with that.
I'm thinking of, I guess, temperatures.
Oh, there you go. That was yeah, for sure. Very good. I like that one. That was temperature controlled. Very good. All right, Maggie. So rest and sleep. Choose a disease, and how are you going to address rest and sleep? Which one? Okay. Okay. I'll throw you for a loop here. What position are you talking about? How if somebody has respiratory issues, then what's a good position for them to sleep in? Okay. Why is that beneficial? That's you're right on your train of thought. Why is it more beneficial for someone to sleep on their side? What have you done? Okay, so someone's like this and they snore. Someone's like this and they don't. What did you change? Yeah. So you move them to what? Someone help her out. What's the term? You moved it to a gravity eliminated plane. Absolutely. It's easier to breathe on their side. If they're having a lot of respiratory, so you're not going to notice the difference because we don't have respiratory issues, right? But someone who has respiratory issues may benefit from sleeping on their side because they're not having gravity pushing down on them in order for them to get their chest raises, right?
Could you just incline them also?
Yeah, you could if you wanted to. They could sit straight up if you could sleep that way, but I mean, that's
Well, I
freaky.
mean like a 45.
What's more normal? What's the more normal? Huh? What about a pillow?
Are we talking about positioning, raising them?
Yeah.
Yes, but I'm asking what's more slightly or inclining them to the point that's going to make a difference. You remember, because if you're here or here, your gravity eliminated is not nearly as much from here to here, you know?
When I have like really bad allergies or something.
Well, that's for sinus drainage. It's different. It's different. It is. It's easier to sleep for someone to breathe when they have respiratory issues on their side than it is on their back because it's in a gravity eliminated plane. Okay, it was really good, Maggie. I'm glad you used your dad as the guinea pig there, but cool. All right, faith, education, work, and volunteering.
Use SMA take 4.
SMA for 400. Okay.
So, towards like an adult at work.
Okay.
So, we can just talk to them about what their job is at first.
Okay.
And what they're having trouble with at work.
What's an area that they may struggle with type 4? Okay. So I work at an office job. I have SMA type 4, and I'm a paper carrier. I take papers to the boss.
Using like a cart.
Perfect. That's exactly what I'm looking for. Very good. All right, community mobility, Faith. Or sorry, Allie.
This would be like an educational thing. Or whenever their symptoms start talking about.
What's your disease?
Let's say B and D.
Okay.
First onset later, whenever they're driving, trying to figure out if they're taking the bus.
Okay. Yeah, finding alternatives for sure. If it's a younger type, that's still good with maybe even Ubering or something like that. Okay. All right. Bring us home there, Cassidy. Leisure and social participation. Okay. 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 So maybe even just finding a support group and yeah, very good. All right. So therapeutic exercise and prepping activities. How does OT address these areas for a person with the myopathic disease? We already kind of talked a little bit about positioning. You're going to talk a lot about transfer safety. Depends on which one you're talking about for transfers, because you have some that transfers aren't really going to be effective, and you have some that they're dependent in transfers. What's really important is really talking to your OT, looking at their evaluation, and talking to the patient caregivers. You have to get a really good picture with patients with myopathic diseases of what their daily function is, okay, where they're at that time, and using what they have to their maximal level, okay? Safety, again, you're going to do a lot. It depends on which one you're talking about, but you're going to do a lot of safety education with the patient and caregiver. Fatigue and endurance, those energy conservation, comp strategies, adaptive equipment, whatever you guys can come up with that's going to help them from fatiguing as fast, because remember, that's pretty much all of them that we talked about. Was fatigue is in there, endurance is there, and strengthening is there, right? Muscle weakness is pretty much in all of them. So there is a little bit of universalism with these that you can work on strengthening. It just depends on what degree and not overdoing it, okay? And lastly would be orthotics. I think that goes without saying. Orthotics probably for contracture management or for foot drop or whatever it may be is going to be really an important part of treatment as well. All right, so we've made it all the way through. You guys have a knowledge assessment on this chapter, not a worksheet. So at the end of the chapter, you should be able to follow or answer the following questions. It's pretty much straightforward. Match the description to the likely condition. Okay? It's not due till, I think, Friday at 2. Isn't that what it is? All right. Any questions? Are we good? I'm going to show you some videos of stuff, but I'm going to stop the recording first.